morning from New York, and good day anywhere you are around the world attending this structural heart live case, particularly today, valve emplacement live case from Mount Sinai Heart Catheterization Laboratories. May I just start with personal welcome. George Deng is here, Dr. Sharma and Dr. Kinney will join us very soon from the labs. If you are at the website structuralheartlivecases.org, you can send us always an email at info@structuralheartlivecases.org with a comment or a question, and I will be going over or introducing your questions into my commentary and my interactions with the faculty during the case, anytime you send them. As usual, this case will be archived exactly where you are, so even if you have to break out and miss some parts of the case, you can view it later, along with the entire blog of questions and answers that can be asked after the case or during the case, and we provide answers later on at the website. Let me remind everybody that next time we have this one will be on February 9th, and our annual complex coronary heart and valvular and vascular cases will be held at Mount Sinai on June 14 and will end on June 16, 2016. And registration will start soon, and you can check the website cccsymposium.org, the 3 C's in the beginning. Again, the 3 C's in the beginning, cccsymposium.org, June 14 to 16, here at Mount Sinai Heart live. Let's go now to the catheterization laboratories to meet Dr. Sharma, Dr. Kinney, and the TAVR team. They're preparing now for this very interesting case. Good morning, and we can see you very well.
Okay, good morning. Maybe we have the whole team here, as you mentioned, and welcome all to our viewers for the structural heart live cases with my team, with Jason Kovacic, of course, Dr. Kinney on the left side, Kovacic behind, and fellow Asad Khan on the right side, which is structural heart disease fellow. And our surgeon today is right in the Dr. Paul Stelger. Yeah, Dr. Paul Stelger right here. Just looking for his face.
We can see him very well.
Yeah.
He is right
Good.
in the center, very well. Dominates the screen.
That's it. Good. Okay. All right. With that note, we start the case. Today is our CoreValve implantation on a high patient, and we can present our first slide. Go through quickly the slides before we go to this echo, so that we can go with the presentation. These are our supporters. Next. These are our disclosures. Next. Now this is a 84-year-old male. Patient has exertional dyspnea. He presented actually a few months ago for management of his cardiac symptoms. So we did a cath at that time. He had a moderate RCA disease and severe AS. And then the idea was that what to do with the patient in terms of the surgery versus the TAVR. He underwent CAT scan and other found to have a renal tumor. Therefore, then question came that he needed a nephrectomy first with a severe AS, and he has recovered from the cancer of the prostate. So what we did is we did a balloon aortic valvuloplasty, cleared him for nephrectomy. He recovered and now back with us with a creatinine of 1.2 today. 2.2, sorry, 2.2 creatinine. So they clearly took some hit. Even usually in the normal person, taking one kidney out doesn't affect the creatinine, but in this elderly patient, I'm sure he has bilateral atherosclerotic renal disease also. So he has severe AS, which will go through it, and just mild pulmonary hypertension. Next. And these are our good vascular structures with our STS risk mortality of 9.5 and consider very high risk, and for CoreValve Evolut-R 29 millimeter. Next. Now this is echo. Now we'll give it to Partho to talk on this issue about echo in this particular case, which is a severe aortic stenosis. That was at the time of the valvuloplasty, and now where we are, Partho.
Yeah, thank you, Dr. Sharma. So the team back here comprises of myself, my fellow Amir Ali Ahmadi. Then we have also the anesthesia consultant Alex Mitnack and the fellow David Shaparo. What you see on the screen right now is the transesophageal echo, and this is a short axis echo and a long axis by two views shown simultaneously. What is very appreciable, this is a tri-leaflet valve, extremely calcified. So this is, my pointer is indicating towards the right coronary cusp. You can see the huge mass of calcium on the right coronary cusp, and in the orthogonal view you can see that calcium plate extends right up to the annulus. So this is the point of the annulus. This is the left coronary cusp, and this is the right coronary cusp. The right coronary cusp again has a huge mass of calcification, which is very clearly identified here. And this is the color flow, which shows severe aortic stenosis. You can see here the restricted leaflet motion, mild aortic regurgitation. That is very well appreciated. And also what you identify when you do a three-dimensional view, that the annular area is extremely elliptical and the calcific masses extend into the annulus. You can see here the three spots of the calcium. This is a three-dimensional reconstruction done, and what we calculated, the perimeter is about 7.5, but the diameters are extremely difficult in presence of calcium, where approximately 1.7, 1.9 the shortest, and the largest was 2.7, 2.8 on the transesophageal echo. Again, the calcium causing a lot of shadowing. In addition, you also see here that the calcification mass is extending into the annulus. This is the annulus showing the dynamic view. This is very important information because this poses the patient at risk of complication of paravalvular regurgitation and annular rupture both. This is the gradient, again showing very high gradient, mean gradient of 44 millimeters recorded today. So the patient, again, despite the balloon valvuloplasty, continues to have severe aortic stenosis. And in addition to that, the patient also has mild mitral regurgitation and some mild inflow gradient because of the calcium across the mitral leaflet. So again, the couple of very important points are the extremely calcified tri-leaflet mitral valve, aortic valve, which extends into the annulus, masses extending. The worrisome masses are on the right and the non-coronary cusps. And in addition, the patient continues to have severe aortic stenosis and is indicated for the TAVR today.
Beautiful. Now we can go back to the hemodynamics again and the angio. You can see there our screen hemodynamics similar to 60 millimeter the peak gradient, and the mean will be about the same 44, 45, and the valve area clearly very significant, so very high gradient.
Very high gradient we see here, exactly.
So what Anu did is that tried to go with the AL1 and required to get a good position of the catheter. So after the AL1 went into the ventricle, we can go back to the floor and then exchange to the pigtail, and that's where we are now, ready to advance our extra stiff wire in preparation for the valve.
Yes.
Yeah. Yeah, I'm going to show you. Yeah. So now while we doing this, while we are changing it, now we go to the continuation of our slides. And this is most important issue about the calcium in this particular case, as Partha has mentioned. And now Dr. Kovacic will tell us a little more about the issue in terms of the calcium and so on and so forth.
Yeah. Thanks. Good morning, everyone. Just next slide, please. So as Partha has indicated already, the key to this case is that large piece of calcium. We got very similar measurements for the aortic annulus for valve sizing. The maximum diameter across is around 27, 28 millimeters. We measured right across in the short axis there where you get 22.4, but if you exclude the blob of calcium, which was what Partha did with the echo, we get about 17 millimeters as well. Perimeter we got around 79, so this clearly lands us in the region of a 29 Evolut valve. Next slide, please. This is just to highlight to you that large blob of calcium that Partha was showing you on the echo in the region of the right coronary cusp. Very significant. We have to take that into consideration today. Next slide.
Yeah. Now the question comes is, I think this is, we can pause here for 1 second. Now once you have this much calcium and then you try to put a valve in, will it not be, should not be the strategy that in this case you do a maximum pre-dilatation, so that after implanting the valve you don't need to post-dilate, because otherwise it will push the calcium further. And actually we have one case where the calcium spicule went to almost to the aorta and caused kind of a aortic dissection. And so, actually that patient needed the limited but surgical repair by Dr. Stelzer. So now,
That's correct.
Doctor, you want to comment on it, JK and maybe Dr. Stelzer?
Yeah, I mean, absolutely, I agree. This is the key to the case, and the generous pre-dilatation to help us avoid post-dilation will be important. And I think also in this case, we need to be prepared to accept mild to moderate aortic incompetence at the end and not get carried away with aggressive post-dilation if at the risk of annular rupture.
Right.
Dr. Stelzer?
There's a little bit of difference between this and the one that Dr. Sharma was mentioning. The previous case was in the non-coronary sinus. And in the aortomitral curtain, there isn't a lot of support. So that kind of fractured and then broke through the subannular area right out under the curtain, causing a periaortic hematoma. This one is in the right sinus, so we've got the muscular part of the septum behind us, so I think we're going to be a little safer in terms of annular support, but it is a very asymmetric calcification that we'll have to be very careful of, and I think your plan of pre-dilating and then not getting too aggressive post is a very important one.
Okay, next.
And I can just add that same glob of calcium in the long axis of this annulus would be far less problematic for us, but because it's across the short axis, that really constricts us. Next slide. So these are the measurements. Sinus of Valsalva is 40, very generous for this valve. Sinotubular junction height is fine. Ascending aorta height is fine at 30 millimeters. The annular angle is 52 degrees. Very standard sort of measurements here for a 29 Evolut valve. Next slide. Coronary height, the left main is about 16 millimeters, which is fine. Anything above about 12, we're very comfortable with. And in that context of the large sinus of Valsalva dimensions, we're not at all concerned about coronary occlusion for this particular case. Next slide. These are the access vessels. You can see fairly generous all the way up. Next slide. You can see there the common iliacs are around 8 millimeters bilaterally. External iliacs still around 8 millimeters. Next slide. And here is the high common femoral where we've stuck bilaterally about 8 millimeters. As we get into the mid common femoral, some calcific disease, so we deliberately stuck fairly high bilaterally to avoid that calcification in the common femoral and ensure we got good closure.
This is a very, very important aspect. Let's just stay a little bit as opposed to fly through it. But as you can see, going high, always a low risk in the retroperitoneal and etc. But you have to understand very clearly how important it is to have a mid-calcification in the common femoral artery. Then this means your perclose device will fail. And therefore, if you have a very clean vessel, a little higher, as shown in this very nice slide, you have to go where you have the good closure potential. Otherwise, if you try to you think you're conservative, you may end up with closure failure because of the eccentric calcification, which is quite heavy, as you see at the bottom part of this slide.
If we can go back to the fluoro 1 second. And JK, you can comment on where your micropuncture was.
You can see here we've stuck exactly high in the common femoral, and that accuracy in putting that needle in exactly where you want to go is critical for success. If we'd been another inch lower in this stick, I think we would have failed and likely had a vascular complication.
we see the calcification actually
eccentrically.
Right
below you.
Doesn't look so impressive here, but it is very impressive by CT, and you know, clearly the fluoroscopy underestimates the calcification density.
Again, on the left, we've stuck fairly high. We do at times stick higher than this. Any higher than this, we'll routinely put a safety wire down so that we can be assured to have balloon closure if we've got any problems with leakage and potential retroperitoneal bleed. But this is about the level as high as I'm prepared to go before we start putting safety wires so we can balloon it if we need to.
Okay, go back to the slides, please, now. Yeah.
So just to summarize all our measurements, this is clearly a 29 Evolut valve by all measurements. You can see there our patient in the 29 Evolut sizing chart. Next slide, please. So just to summarize, Dr. Sharma.
Yep, yeah, basically, so that we are ready for the 29, next. And Evolut is the one. Next slide. Basically, this actually has been a, I would say, from our interventionalist point of view, you know, you ask for a kind of near perfect or perfect TAVR valve, and that Evolut-R, in my opinion, comes that close. And of course, it's still not available with the 31 millimeter size, but various sizes. And of course, the regurgitation, because of the skirt further down and covering those struts, is much less. Next. And this really has revolutionized, in my opinion, because of the smaller sheath size. Next. And the various inherent the characteristics of what they made the Evolut-R different from the CoreValve. And Anu can describe now our experience of the Evolute, and particularly when we used to do our core valve, not knowing where it is going to settle, and how the Evolute has changed our procedure. Anu?
Done almost close to about 60 cases since Evolute has been introduced. But the most important thing, I think, with this device is that the sheath size, which has tremendously gone down. If we don't have to pre-dilate, and of course post-dilation is not known, but based on the echo and the CT criteria, when we know we are likely not going to do pre and post, the great thing about this is go with the sheath that is 14 French, go ahead, deploy the valve and just come out. And other thing is that we are able to recapture the valve. Compared to your previous, the core valve, once they have introduced recapture, if you think about it, we recaptured only 2 valves in the 60 cases or so that we placed, which are trying to tell you how technology has got better, that once you start releasing the valve, it actually able to anchor and just stays where it is, compared to the previous core valve used to move, sometimes could go down, jump up, jump down, especially with the 31. The precise placement which we as interventionalists like to do was not available in the previous core valve, but that technology is now available with this, with a safety feature that you can recapture. But actually, to tell you, the truth is that this valve is doing very good without able to recapture, that able to place and stays. Once it anchors, it just stays and release immediately.
Yeah, I think that's a very good analogy. But, in the past, you open the core valve where it will settle, nobody knows, while Evolute, it stays there. I say that, the Medtronic has put probably a little crazy glue around it. So once you open it, it stays there, it doesn't move. So this is a great feature from our point of view. So with that note, I think we are ready to insert. We can go back to our, the presentation is complete, and now we go to the actual live case. We have a pigtail in the ventricle and advancing the catheter, the wire with the exchanging for the balloon valvoplasty.
One practical point, to cross this valve, we needed AL1 catheter. With the AL1 and straight angle Terumo, we were able to cross. But once we are in the ventricle, it was not in the mid cavitary. In that case, it's very important you go back with your exchange wire, use a pigtail, make sure your pigtail is in the mid cavitary, and that's where we were. And after that, you will get your stiff wire in.
And this is a very important step, because in the past we used to kind of shortcut it, but that creates a problem, even rare, of the coronary, the LV perforation and so. So key is that manipulation of the Emplatz catheter in the ventricle is risky. So if you have some question about position, you go back with the exchange length wire, change it to the pigtail, and pigtail will get you to the apex.
So we are now getting ready for the BAV with the...
The pressure is on lower side, 22 Zmad.
Can we increase the pressure?
Yeah, we'll be ready to go in shortly.
Very important to see what a great curve there is in the wire that allows a safety around the apex as the device gets introduced in the
who has the pacemaker?
LV
120
through the AV.
Pace
120. Good.
What balloon? You want to tell us what balloon you're using right after
this?
Is
Is that 22 Zmad? We have gone up, and then we are using the small syringe to...
Cine, please.
This is...
Cine.
Okay, done. Stop pacing.
Good.
All right, retrieve it a little bit now into the thing, the stop the pacing, which is what the pace rate do you use here, 160, 180, or 140 for the BAV?
I think 120. Pressure is just about 80 or so now coming up.
What's the wire?
You don't need it that low.
Advanced. So whatever captures is usually 140, 180, and this one was 120. And now, okay, clearly that sometimes it will create some regurgitation. Partho, any further change before we put
there is only mild aortic regurgitation.
Good.
We need to get the pressure up
You get
again.
the echo image a little bit if we can. Yeah, yeah, there's a really trace AI, very good, minimal. And we can appreciate very much the calcific structures there at the annulus in the echo picture. Let's see how that works out.
Hop in. This is the one we turn this way.
Pressure is so low.
Yeah. Pressure is on the lower side, slightly. Good.
Now
It's
coming up.
Good. Go in. So we are going in now.
Perfect.
Why the diastolic is 40?
Now this patient, we require an intubation, about like kind of half and half for us, conscious sedation versus intubation. And this patient particularly, we are very much concerned about this calcium. So wanted to be a full control.
And
from
we see the
anesthesia
valve
point of view.
going very nicely around the arch and into the LV. That's where the wire is very helpful with the curve.
Okay, what is the yellow
It's all this interference.
from white? Do you know? What is the yellow interference?
One of the, I think.
Okay, one of your transducers, look into it, please. The wire yellow is. Good.
It's okay.
2 minutes. Yeah, good. Now it's working.
Magnification, can we go low?
Low, yeah. Okay, so now we are ready to see. We are into the view where the pigtail in the non-coronary sinus.
Some dye.
Let's take a look at it.
Creatinine is high, right? So I think we are okay here.
We're okay,
Everybody
start.
happy? Yeah.
Yeah.
Do we cine or no?
Yeah, this one we start without
One
it.
cine.
The less creatinine.
Okay.
Yeah, not yet. Once
Okay,
you
okay,
flare a
okay,
little
okay.
bit, then we do.
Yeah.
Cine, so
We
you
have
can
to
see.
go down a little bit. Okay.
Okay, starting to
Flare now.
should flare
This is a
shortly.
very well controlled mechanism for the release of this
Okay,
valve.
early
Like you
flare
can see
coming.
now, it
Yeah.
flares slowly after
Great.
after the sheath has
Let's
come
go
way
cine.
back.
Okay, inject.
Now inject.
Looks
we're
like a
just fine.
perfect position.
Shall we?
Yes.
Yeah. Okay.
Pacing or not?
Yeah. Start pacing at 120.
Pacing at 120.
Looks
Okay.
like a
Yeah,
perfect
go.
position.
Yes.
It's
So
anchoring.
continue the control
Okay.
release, and you can
Now it
appreciate
anchored.
how the valve doesn't move, the bottom part of the valve as it gets released. And
Okay.
always gets a little eccentric, but
Stop
Okay.
pacing.
Ready for another
Stop
injection.
pacing.
Stop pacing. 60.
Good.
yeah, I don't think it moved at all. That's great.
Move back the pigtail.
Are we okay with the left side?
Yeah.
Very
It's
good.
not- It's not
Good.
too
Pull
deep.
the pigtail up.
Okay. We are ready to release.
Yeah. Good.
Okay.
Okay, now we're proceeding with the full release. As you saw, there was no movement in the valve, and we expect to see a realignment of the valve as soon as everything is released. Right now it's tilting a little bit, but usually there is everything realigns. Indeed has, as you can see,
We're released.
Okay, advance the wire a little bit.
the angle has changed favorably.
Yep. And now we remarry here.
Mhm.
See where's my button?
All right, we're going to see the TE, or we're going to try to remarry the two and
Good. Okay, coming out.
remove
Leave-
it out
leave again.
now.
Yeah.
We can see the TE a little bit while they're removing the valve.
So the valve is clearly underexpanded, and you can see there that there is a significant moderate to severe paravalvular leakage present.
Yeah, it's
Oh,
over
indeed, up there in the
It's
anterior.
interesting.
Wait,
It's in the
wait.
non-coronary
It's
sinus.
undercaptured.
No.
Now try. Now try.
So at this point, we have to reevaluate the entire situation. One thing which I wanted to point out to the interventional team is that the pacemaker wire tends to jump a little bit towards the RV apex.
Mm.
So and it's irritating the surface. So there's that needs to be pulled out a little bit towards
You
the
need to
cavity.
pull the.
Pacemaker a little bit.
Yeah, because it's causing a little bit of small.
Now,
collection
do we
there.
go with what Partho says so we don't have to do an aogram?
And clearly paravalvular underexpanded.
Okay. What size
Leakage.
will you-
The 22, 23.
Okay, what is the picture-wise? Why this not coming out
Echo.
good? Echo.
Oh, you want the echo? Okay, one
No,
second.
echo is coming there. Yeah.
20, 23.
Yeah. Get
So
it.
you can see here the paravalvular leak on the top. It's underexpanded here. You can so if you follow my pointer, so this is the valve
Is that where
strut,
the specule is?
and this one is the margin, and this is the gap in between, and
There is a gap though.
yes,
Yep. About 0.5 millimeter gap.
yes.
And interestingly, it seems like a uniform channel there. 1 plus AI for sure from
And
this part.
It's not around where the big calcium was.
Yeah,
it is.
It's the opposite wall.
Yeah.
The big calcium's at the bottom of the screen in the short axis, and that seems to be okay. Tiny little leak over there.
Well, there were 2 chunks of calcium actually.
Yeah.
A big and a not so big.
Yes.
Who has a pacer? You have to go 180 now.
All right, what size balloon are we using now?
23. ZMed.
Well, we're 23 Zimmer. We're going to go a little bit further in the ventricle than before because we're gonna we're going to yeah, that is more than enough. That's
Okay,
perfect.
start pacing at 180.
So this has to be a
And
gentle
we have to have full
inflation.
capture before we go up in order to avoid
Okay,
the
just
valve
going up.
moving. That's a routine of this procedure, and you see how
No, good.
Too small.
Too small.
it looks like not as big, but let's
Maybe
get a
okay.
full expansion of this and see how
Okay.
it
Yeah,
goes.
yeah, we cannot.
Expanded actually, and we continue to pace all the way until the balloon is out. This
Okay,
is a proper
60 please.
technique of this. It's a prolonged pacing, but it's necessary to avoid movement of the valve.
It just depends what axis you're looking at. If we've got
Let's see where we are now, Partho.
Yes. So
I think the channel became less.
yeah, it has become less. I agree with that, and I don't think because of the calcium there is any further expansion possible. There's a mass there sitting, and any further attempt to do may puts the risk of annular rupture. So at this point, I think the interventional team needs to make a full hemodynamic assessment, and they then make any further determination. So the grade of paravalvular leakage is mild to moderate. And I think it's good to stop here and reassess what
Let's try to
is
do
the hemodynamic assessment.
Very good. And pigtail now is inserted in the LV, and we're going to see now the hemodynamics. Let's go
Pace-
to hemodynamics, please.
Pace it. You need
We
to
see
pace,
LV.
pace at 50. There's some
We need LVAO hemodynamics now, please, on our screen. Okay, very good.
We
What
need to
happened to
pace it a little
the
more.
yellow? Open this.
We have
Are you pacing?
AO, but we don't have LV.
Yeah, 1 second's coming.
Yeah.
No, that's okay. Listen, I'm okay with this.
Yeah, very good. It's
Different
paced.
branches. Okay.
Let's flash both and zero both because
Yeah, zero both of them.
something doesn't make much sense here, hemodynamics, or there is
Some
yeah,
AI.
there, but let's or the significant AI, or we have to
Zeroing?
reassess the.
Diastolic is gone down.
Zeroing. Okay, zero both of them.
Yeah, please zero and flash both of them. Yeah, all the lines and including the red.
Red. Good. Okay.
All right, so that.
Can you open the blue?
Yep, you're done. Okay. I mean, there seems to be some more regurgitation, but I think there's no systolic gradient, so that is less than 10 millimeter.
Well,
Part of it's a slow rate,
Yeah.
too. Gives you time for a lot of that diastolic
why don't we pace at 80 and see
equalization.
how it goes?
Okay.
80.
Pace to 80, please. There you go.
Yeah. Yep.
Things are better.
Yes.
Fast heart rate always makes AR look less.
Beautiful. Pace at 80, and we can see that the diastolic LV pressure now it's okay. You pull it out because about 20, and the
Again, the pigtails
AO
are-
diastolic is about 60,
Oh, sure.
which is very acceptable, I think.
Yeah.
Let's go with the.
Okay. Ready?
Yeah,
Everybody ready for the
15.
And let's
Yeah.
go to the 1 second, please. We're not set up here. Let's go to the angiogram.
yeah.
Yeah.
Okay, we can see you now, but not live. Yeah. We can see the pigtail a little bit
Okay.
inside the
Inject.
aortic valve. I think there's 1 plus AI here. I think that's very acceptable according to what we saw in the hemodynamic as well. 1 plus.
Yeah. And echo-wise, Partho, you are moderate.
moderate.
Sometimes we
It's,
may not be fully satisfied, which is okay. In this
I
case, we
agree.
started with-
I agree that this is a good point to call off on this case because the AI right now paravalvular is mild to moderate, but it will reduce subsequently, and there's a huge risk of an annular rupture if you try to dilate it any further.
Okay, so then in case, I mean from procedural point of view, we are okay here. We go back to our presentation, and we can take off the echo also related to the case. Every month, I mean every presentation we try to make one point. In this case today, I'll just talk about the latest data of the DVT Registry, which just still in the ahead of the publication in JACC, main JACC, and basically the effect of the learning curve. So next, actually before Dr. Stelzer goes, any want to comment on, knowing that the technology is so good nowadays? Well, if the choice becomes available.
This is just one of those things that makes a surgeon glad we've got this available. That STS risk of 10% mortality, this guy needed TAVR. 5 years ago, he wouldn't have gotten it. So beautiful. I'm thankful for the opportunity to work with you guys and make this happen for people that we couldn't help otherwise.
Fantastic.
Great.
Okay, so now we basically, as you know, the STS ACC, just like ACC NCDR for the coronary interventions, the transcatheter valve therapy was established in 2012 after the commercial availability of the Edwards SAPIEN valve. And the process was that they will enroll all consecutive TAVR patients, particularly those who are in the commercially available, accept all manufactured devices and follows the patient for at least 1 year. So it's a great thing, because then we will have the data on a large number of patients that what is the trend. Next, the aim and purpose of the registry was the generation of important descriptive information regarding evolving trends in overall patient selection, device use and outcomes, then development of validated risk prediction models, the ability to provide individual patient risk predictors, and also most important is you always want to know how you are doing compared to the national standard. So basically the benchmarking of the site and provider level outcomes on the basis of patient risk. Because we all know your simple case, low risk, high risk cases, you'll have higher complication. So clearly that it's a risk adjustment into the overall outcome comes in. Next. So basically we just, you know, as I said, this is ahead of the pub. Next, the overall giving the data up to 2014. Now we have 350 centers in the United States, which represent 48 states of the 50 where the TAVR is available. Next, and then what they did is basically compared the 2012 and 2013 together with the 2014 to see the trend. Now overall, clearly that in 2013 the CoreValve added with the Edwards SAPIEN, and then of course SAPIEN generation changed, and then now 2014 we have the CoreValve as well as the SAPIEN XT. Overall mortality, as you can see, 5.54 has gone down to 4.4. Next. And this is basically the age. Age remains still the same, that our majority of our patients are in the age of 80 and 90. And of course, about 10-15% of patients are more than 90 years of age. Next. Now, STS risk score, you see distribution. Next, there is slight decline in the overall STS score, but majority of the patients are truly that high-risk patients now. Next. And what is the device performance? Excellent. Overall success rate over 97%. And so, and of course, the case like which we showed here, less than 10 millimeter gradient is almost achieved in all, I would say, 96-98% of cases. Next. Now, this actually puts together various types of procedural type, but just wanted to add the conscious sedation. As of the DVT registry report is still done in single digits in United States. Conscious sedation, deep anesthesia. At Sinai, that number is close to 50%. So about 50% of our patients are getting conscious sedation. Conversion to open heart surgery is about 1%, and the need for the cardiopulmonary bypass is just very small, 3 to 4% of cases. So overall, various you see the need for surgery and indication for surgery are shown there, but rare occurs in 1 or 2% of cases. Next. And this is basically the aortic regurgitation kind of remain the same, that some patients you will see that you will leave more than mild aortic regurgitation like 5%, but majority of the time the patient comes out with a mild 1+ or lower regurgitation. Next. Now this is the complications. You can see in hospital mortality, and they have made it first 2 years to the then compared with the 2014, that 5.3 to 4.4, major bleeding and vascular complications all have declined, while stroke rate remained low but no change. But key is look at the 2% stroke rate, which we know that stroke rate was much higher in every trial, but here they have 2% in the registry, and I'll come back to this point a little later. Next. And these are the various other complications which basically are rare. Next. Does happen, and therefore the purpose which was the TVT registry was set for, in my opinion, met, that the TVT registry provides important information on characteristics and outcome of TAVR in contemporary US clinical practice. It can be used to identify trends in practice and opportunities for quality improvement. And we hope, just like the ACC NCDR give the data that quarterly your site performance to the national performance, we'll start getting the data from the TVT registry. You compare on your similar risk status patients, your STS risk status patient, that what are your outcomes compared to the national TVT registry, and that will be a huge learning for the centers, for the interventionalists, so that they can change their therapy. Next. Now also POPMA presented recently the CoreValve, the TVT registry with the 1-year data, because the data which I showed earlier, TVT was only in hospital. Now we have the 1-year data of the CoreValve. Next. Part of the TVT registry, and STS risk score kind of remained still high. So basically the TVT registry 6,000 patients compared to the extreme risk and high risk pivotal trial, which is 1,000 patients, about 9% was the STS risk. Age still remains same, that majority of these patients are more than 80 years of age. Next. Now these are risk, basically the complications or outcome, 30-day, all-cause mortality, the stroke, and so forth. You can see clearly the stroke rate in the registry is almost half of what was in the trial. Now, whether it's a right or wrong, but this is consistently what we are seeing. Maybe it's under-reporting, because remember, this is the voluntary reporting. They have not started the audit process, which the ACC NCDR has yet. So maybe things might change. And also very important is the vascular complication, which was tremendously high. Now learning the techniques and of the device, and so vascular complications have significantly gone down as shown here. Next. Now this is, people ask, what about the learning curve? Are you going to change your mortality over the years? And I can tell you that just what we noted at Sinai, that maybe first 6-8 months where we were doing TAVR in everybody and then not realizing extremely frail case or severe COPD who will not walk out of the hospital, so the TAVR is not for them. Maybe do balloon valvuloplasty, but overall it seems to be that there is no true learning curve in terms of the mortality. So it remained around 5% amongst various quarters, and similar data was from the overall TVT registry. Next. And now the 1-year data, and this is an important additional information than the TVT registry we had. This is basically on the left side is the overall with the extreme risk and high risk of the TVT registry or the CoreValve, and the right side is the US CoreValve extreme high risk individual group. Now overall you see that very important observation. You can go step by step and each numbers compare with other number, that overall, as you can see, the mortality point of view, we are done extremely well. Now you say, well, this, how does it matter? Well, we always knew that any device, once get approved commercially, people tend to use it more indiscriminately without a system in process. What it really, this slide highlights, and this is the data of our TVT registry also, that outcomes of the patients who are in the registry are as good as, if not better, than what was in the randomized trial. And this is a very, very important point. And this is exactly what we show here. The very clear point on top of it, that lower CVA rate and lower vascular complication. That we say, okay, site reported, maybe under-reporting. But what you cannot get away is the mortality. The key is that even in the widespread use of the devices, these devices which are very expensive, system consuming, and so overall mortality remains similar in the registry as compared to the CoreValve at 30 days or as well as at 1 year. Next. So basically, if the take-home message that participation, the CMS mandated TVT registry has shown excellent TAVR outcomes similar to the randomized trial. These data underscore the heart team approach and system setup in the hospital performing TAVR procedures. Next. There has been a clear decline in the incidence of CVA post-TAVR. I would say as long as also as the vascular complication compared to reported in the DVT registry and the randomized clinical trial. This could represent underreporting of some TAVR complication in the registry, or it could truly be the declining CVA rates due to better case selection and better procedural performance. I think it's a contribution of both, because clearly that you may miss some TIAs or some MRI defects, but you have a CVA. CVA is just CVA. With that note, I have my 3 questions while we are finishing our vascular closure. Question number 1. The recent DVT registry TAVR data reported the following except, means what is the wrong? Registry cases have shown slightly lower mortality every year since inception. Registry cases have shown lower bleeding over the years. Registry cases have shown lowering of the CVA incidence over the years since the inception. Registry cases have shown lower STS risk score of the AS cases over the years. Next. Second, approximately how many centers are performing TAVR in the USA by end of 2014? 100, 100 to 200, 200 to 300, or 300. Next. And the last third question is the DVT registry CoreValve data compared to randomized clinical trial have shown the following at 1 year. Similar mortality, significant learning curve over the years with lower mortality, lower CVA rates, and higher STS risk score. Next, I think I felt that maybe we'll start giving the question answered at the same time. This is the case basically where next, that answer is C, that what is the wrong? The registry cases have shown lowering of the CVA incidence. What has shown? Lowering of the CVA incidence compared to randomized trial. But whatever the 2% was has not gone down to less than 2%. Next. The centers, next slide. Clearly, we more than 300 centers. There's about, I would say, just to say that the full service cath labs doing a complex intervention in United States are about 1,600. So we are about 400 now. So about 25% of the labs are performing the TAVR procedure at present. Next. And the lastly, that in the CoreValve, the answer is B, that there is no significant learning curve over the years with the lower mortality. And that really goes down to the system setup, the company mandated, the training of the staff, of the physicians, and of course everybody involved in care of the patient, and more importantly, the guidelines which have been set up by the CMS, that what should be the number of structural cases done by the interventionalist, what should be the center doing the aortic valve replacement, and so all that has resulted in excellent outcome of the TAVR in the real world. So with that note, maybe we can take a last word from Jason, that where we are, and we conclude our today's discussion.
Jason,
Sure.
where are we with a closure?
We're done.
Wow.
So just to show you here, what we carefully do is we access the right side, and in this case, because we expected multiple balloon exchanges, we actually put a sheath in. This is an 18 French solo path sheath. So the first shot you see here is a DSA. You can see the tip of the sheath is down there in the right distal external iliac. We've retracted the sheath. We're checking for no perforation or problem dissection. You can see here on the right side looking good. The next shot, we've actually we're looking over the common femoral now. We've deployed the perclosed sutures. We still have the wire in, but you can see here, tiny little pinch. There's often a little spasm initially right on the common femoral head. Wires out, sutures are cut, and this is our final completion angiogram shot here. Nice result, no extravasation, no pinch,
result.
nothing.
You know, then again, this is due to the excellent selection of the spot that we went through before the case. You got to avoid the calcified spots in order to get a closure like this one.
Yeah, now I actually ask another question to Annu about, I think knowing that the TAVR has become so simpler, I would say relatively simpler, and the system setup, I think we should make it a clear-cut plan, discharging them methodically, identify patients who are good, have a low risk of any complication, discharging them in 24, 48 hours. What do you comment on it, Annu?
Yeah, probably we go for 48 hours first. Procedure itself decrease a lot of the things that we do. Most of the time, we do not have the swan anymore. In this case, we did have to have a neckline with a temporary pacemaker, and patient actually is partially dependent on the pacemaker. If not for that, I think most of the lines, since anesthesia is involved, they do like a line, but if we can get majority of the lines out of the patient, then when they go to CCU, in this particular patient, the goal could be that try to ambulate within the same day, or maybe later part of today or by early tomorrow morning, then move on to telemetry tomorrow with the plan to discharge either later tomorrow or early by Thursday morning. That should be the goal in this kind of cases. Here one of the drawback could be we may have to monitor the creatinine. What was the total dye use? 40?
Yeah, I think
about 40 or so.
I think it's a good plan to shoot for 48 hours, and then extensively really the window 48 to 72 hours more realistic for a first goal, and then maybe in 6 to 12 months we can move to the 24 hours even in more easier cases. Remember that the 24 hours used in primarily Europe and Canada, where the TAVR is expanded use, including low intermediate risk, closer to even low-risk patients in some categories. So there's a little bit of a, when we read their data about fast tracking, they really include different kinds of patients that in the US. So I think that would be a reasonable plan. As well as a reasonable plan is the simplicity of the monitoring during the case. What do you think about that, Dr. Sharma? The TE, the intubation, all those things might continuously have been reduced and will be reduced even more in the months to come, no?
Yep.
Yeah, I think other thing you can also do is pre-select the patient, based on what we are going to do, what anesthesia is going to do, and based on the echo, that instead of TE we move to transthoracic, decrease most of the lines with the minimal monitoring. In that case, I think fast track will actually change. So that's a team effort. 3 group of people have to decide, pick the patient who will take a fast track versus some high-risk patient may have to be monitored the usual way, but this is a system that we have to put in place and evolving, but likely that's the way we are moving for the 2016.
Now, Partha, you still connected or no? Yeah. Okay. Yeah. Now remember you published your research correspondence in JACC imaging about your TE versus the transthoracic.
Yes. So we have data that is published now on transthoracic conscious sedation versus TE approach. This was a retrospective analysis, and we did not see any major differences in the outcomes of the patients. In fact, we were able to show that the recovery and the ICU stay was lower in number of days in patients who underwent conscious sedation. And we now have been able to work with the anesthesia team, and we also use conscious sedation transesophageal echocardiography using pediatric probe, and that really has provided a lot of confidence, because we get all the information that is necessary. We have a much better delineation of the aortic root anatomy and paravalvular regurgitation, and majority of the cases where we are doing conscious sedation, now we use a pediatric TE probe under conscious sedation, and that's been a very useful advantage for us.
Okay, that's great.
Yep.
All right, I think that we conclude the webcast very successfully. We thank Dr. Sharma, Dr. Kini, Dr. Kovacic, Dr. Stelzer, and Dr. Sengupta, who were part of the key parts of the procedure, the fellows and the nursing team. And let's invite everybody back here the same time anywhere you are in the world, or 9 a.m. New York time if you're in the United States, on February the 9th, again a Tuesday, for another webcast. And let's remind 2 things to everyone. You can come to the same website, and which is the www.structuralheartlifecases.org, and under the archives, and you can view this case again, or you can post a question that we're going to answer later at the blog, and you can also see some earlier archived cases performed here. And also follow the website CCC, again the 3 C's there, the 3 C's, cccsymposium.org for the updates regarding our live symposium here at Mount Sinai, June 14 to 16 of the next year, 2016. Thank you again from the Cardiac Catheterization Laboratory and myself in person for your attendance today. Good day.